you want me to share before he does the introduction?
It's our great honor here to invite Dr. Kathleen Moore to have a talk in this anniversary celebration meeting in our Taichung Veterans General Hospital. And today I will share with Chief Xu about this talk. And Dr. Kathleen Moore is currently a professor in University of Oklahoma College of Medicine. She plays numerous important roles in different professional gynecologic oncology, drug development, and clinical trial organizations. She conducted many important clinical trials, especially in the field of PARP inhibitor. Everybody here knew that she was the principal investigator of SOLO-1 trial and the first author of SOLO-1 NEJM paper. To my opinion, this is a world-shaking trial that led ovarian cancer into the era of true targeting therapy. Today, she will talk more about the genetic of ovarian cancer and PARP inhibitor. Let's welcome Professor Kathleen Moore.
Well, thank you so much for that lovely introduction. And I'm so honored to have been asked to speak today at this conference. And I think we all say this, but it's true. I wish we were in person. I miss actually interacting with my colleagues internationally. And it looks like maybe we're getting closer to a time when we can have in-person meetings again. So I'm looking forward to that. But I'm glad we can get together virtually today from Oklahoma City, all the way from across the world. So I'm going to talk to you about really some pretty exciting advancements in the treatment of women with advanced ovarian cancer. And I think we can finally start to say we're getting to a point of individualizing therapy for women with advanced ovarian cancer based on both clinical and molecular features. So these are my disclosures. I do a lot of drug development and I work with a lot of companies developing drugs for women with gynecologic cancers. The objectives today are really to kind of go over the standard of care in frontline ovarian cancer. We're going to talk a little bit about PARP resistance and then a little bit about some other novel assets that are being developed. But I like this slide. This is my new slide that I start with, and it's from a very nice review article that came out this year. And so I encourage you to take a look at it. It's really quite a lovely review because I think this figure sort of shows how far we've come. You know, I trained in early 2000s. And at that time, if you had advanced ovarian cancer, we took you directly to the operating room and we tried to cytoreduce. And sometimes we were successful and sometimes we weren't. I trained at a very surgically aggressive place and everyone got paclitaxel and carboplatin. And then we saw what happened. That's what you did. There was no individualization. That's just what you did. It was very easy, no decisions. And this is today. And it's even getting more complex day by day. But, you know, we look at patients with their comorbidities. We are better at assessing what the likelihood is that we're going to get somebody to no gross residual disease with our primary side reduction and making better decisions about whether we should do a primary side reduction when it benefits, and I believe it does, or go to neoadjuvant if you're going to harm somebody by taking them to the OR and not getting all of the disease out. So the timing of surgery has become less controversial than it used to be. Histopathology is important. Again, in the day, we treated all ovarian cancer the same. They're not the same. Clear cell, which you see a lot more of, although I just rounded on someone in the hospital with advanced clear cell, it's not the same as high-grade serous, and it probably should be treated differently. We know the importance of staging, that's not new. And really the genomic profile is really the other place where tremendous inroads in treatment have been made. It's essential that we know someone's BRCA status now so that we can do cascade testing for their relatives, but also so that we can get them PARP inhibitors, which may be curative, we don't know yet, but are at least transformative from a progression-free survival standpoint. And to a lesser extent, but still very important, patients with homologous recombination deficient tumors. You'll also know genetic risk, but benefit from PARP tremendously in the high-grade serous and high-grade endometrioid. And so we're starting to individualize our maintenance therapy based on biomarkers. So let's talk a little bit about the testing that needs to go in for women with ovarian cancer. And so they're just kind of the big questions that we ask ourselves, kind of the who, what, why, and when of genetic and genomic testing. And so the easiest question to answer is who should be tested? What women should be offered testing? And the answer here is easy. It's everyone. Every single woman with advanced or even early stage epithelial ovarian cancer should be offered genetic counseling if available and testing. And this is agreed upon by all of the oncology subspecialties. So it's very easy. Breast cancer, hard. There's all sorts of age and family history and, hormone receptor status to determine who gets genetic testing. That's kind of hard. Not that hard, but you have to look at that algorithm. Ovary, easy. If you have a patient with ovary cancer, you should make sure she's been offered testing, period. So that's real easy. Why? Why is this so important? Why should 100% of women be offered testing? Well, number one, it's important now for the patient. It was always important because it gave us some prognostic information, made us feel better that they were going to likely do very well. But it's predictive now in that it identifies women who are going to benefit tremendously from a PARP. And so it does impact their therapy. And so knowing this diagnosis at the very beginning allows us to prioritize PARP inhibitors at the beginning, which is where they work the best. And then the other big thing about identifying BRCA and also the other lower frequency germline genes, Rad51, PALB2, et cetera, is that not only can you identify those who will benefit from a PARP, but also you can counsel families and offer testing and counseling to first and second degree family members so that if we identify these same mutations in non-affected family members, we can offer risk-reducing strategies for both breast and ovary and pancreas. Remember, men are at risk for this too, melanoma, all of the things that are associated with BRCA1 and 2. We want to prevent these cancers if we can identify the people at risk before they become our patients. Critically important. And then if you don't have a germline mutation, if your patient does not have any germline mutation, BRCA or otherwise, it avoids the kind of worry that they've passed that on to families and also unnecessary screening and surgeries that they may not benefit from. So there's a lot of benefits here. Now, when we test for BRCA1 or 2 and the other high penetrance genes, you can do germline and or somatic. And I'm sorry, I guess it's showing up okay. Somatic's a little hard to read, I apologize. But just to remind you what this means, so germline is something you're born with. And so you can see in the figure on the left, every cell in her body has a loss of a BRCA, one loss of a BRCA gene, but she has a normal in the other copy, right? We all have two copies. But in the tumor, both are lost because tumors are unstable, and that's why you get tumors. And in the one figure on the right-hand side, only the tumor has the loss of BRCA. So there's no genetic risk to passing this on or no risk to her family, but there's the same benefit of PARP inhibitor in a somatic BRCA as there is in a germline. They benefit just as much. And so it's very important that we identify these patients and an extra 7% on top of those patients who have a germline BRCA associated cancer who will benefit tremendously, and you want to prioritize a PARP for them. And so this just breaks down of patients with high-grade serous, this is just serous data, ovarian cancer. About 25% of women will have a BRCA mutation, 18% is germline, and another 7-ish% is somatic. And we've been collecting data on this for a few years now, and it's holding right about 7 to 10%. So that's not common, but it's not super rare either. So it's definitely worth testing for to identify these patients. Now, I've mentioned a couple of times, it's not just a BRCA1 and 2 story anymore. These multi-gene panels are very important at identifying all of the high penetrance genes that may contribute to development of cancer, inclusive of BRCA1 and 2, but also PALB2, BARD1, BRIP1, Rad51C and D. And then most panels are also including the mismatch repair genes as well. Now, these are very low likelihood of being mutated in a high-grade serous cancer, but you may find them in endometrioid tumors. And then that opens up opportunities for immune checkpoint inhibitors, which may be the only reason to use an immune checkpoint inhibitor in ovarian cancer. And so I do just bring that up because again, histology is important, and the things we look for in a clear cell versus a mucinous or endometrioid may be different than the things we look at in high-grade serous. So really in high-grade serous, we're watching for these homologous recombination or DNA damage repair gene mutations. And so these multi-gene panels used to be kind of controversial because you really weren't counseling a patient for every single gene and what every single gene germline mutation would mean in terms of their risk for future cancers, which is, very important. And I don't want to minimize that. But that concern about poor patient counseling, I think we've kind of mitigated with the knowledge gained by sending these multi-gene panels. So this really in many parts of the world is kind of the standard of care. There's no cost differential. There's no reason really not to send a multi-gene panel other than sometimes it's confusing what the results mean, when you don't have enough information about a particular variant. So there can be some information confusion with the multi-gene panel. I guess that's one disadvantage, but the advantages far outweigh the disadvantages. And then, so that's sort of the germline and somatic story, but that's not the whole story, of course. And now we know that there are changes to the tumor that render it vulnerable to drugs that target DNA repair, such as carboplatin and PARP inhibitors that aren't mutations. They're epigenetic changes and other changes that render that tumor vulnerable, and we can detect them somewhat well with these homologous recombination deficiency assays that are now in commercial use. And so we have those as well, and I'll mention those. And so when you think about high-grade serous and high-grade endometrioid cancer, this is a pie chart you all have seen many times. You can see the breakdown of kind of what we see both from a mutational standpoint and also from an epigenetic change standpoint, where about 50-ish% of patients, for a variety of reasons, have loss of homologous recombination proficiency. So they're homologous recombination deficient, and that identifies them as more susceptible to anything that targets the DNA, like carboplatin, but specifically PARP inhibitors. And so this has really become transformative information for our patients. Now, the sad side to that is about 50% of the patients, about 10% are unknown, and about 40% tumors are really good at fixing their DNA and are homologous recombination proficient. And these are the tumors, cyclin E amplified, MYC amplified, others that don't respond really well to PARP inhibitors or to carboplatin, and we need to develop better therapies for them. Now, so there's been some, as we've developed all of these new tests and we're trying to individualize to patients, of course, we understand BRCA1 and 2. And the initial kind of next step from that, we talked about the panel germline testing, but the next step from that was, well, let's do panel somatic testing. And you all have seen all of these tests: Ambry, Foundation, Tempus, Caris. There's so many that will analyze the tumor and look for these homologous recombination repair genes that are mutated. And so that was sort of thought to be the next big thing in terms of identifying more women that would be that would benefit from PARP inhibitors. And so this is just a table that shows, or a graphic that shows, the frequency of homologous recombination DNA damage response mutations kind of across a number of solid tumors. Endometrial, we see quite a few. That's surprising, 34%. But ovarian is right here, and it's about 20%. And this excludes, the P10, which we don't really know yet that it works. But about 20% of ovarian cancers overall are going to have some mutation in a homologous recombination repair gene. Now, if you just look at high-grade serous, it's going to be 24%. If you're including some of these clear cell and mucinous, it kind of brings it down a little bit, but overall it's about 20%, which is pretty reasonable. So it seems like something you'd want to look for. Now, so that's homologous recombination repair panels, and I'll come back to that. The other thing that I've already mentioned are these homologous recombination deficiency assays, so HRD. So which one do you use? Because you could use either, right? You could get your Caris panel or your Tempus panel and have this homologous recombination repair panel and try and predict response to PARP or who should get a PARP. Or you could use these homologous recombination deficiency assays, HRD. And so there's differences, they're different. So, and I like this graphic. This is from Dr. Pujal-Lorraine's presentation of PALA-1, and I stole it. So in blue is the HRD assay. So the HRD assay is looking, it identifies tumors because it can see the consequences of that tumor having trouble fixing its DNA. When tumors have trouble fixing their DNA, they leave evidence of that, the kind of a scar or a tattoo. You've heard different comparisons, and we can pick that up in these assays. So the assay picks up the consequence of that tumor having homologous recombination deficiency. So the importance of that is that it tells you that homologous recombination deficiency definitely existed. Otherwise, you wouldn't have the consequences, but it doesn't tell you it still exists now. So if you're testing someone in the front line before they've had any kind of treatment, it's probably a pretty good reflection of what's actually there. But the problem is, and I'll talk about this, is later on, if you're testing archival tissue or even in a new biopsy, the consequences of HRD, that assay will still be there, even if the tumor has figured out how to fix its DNA. So it's kind of a historic document, but it does tell you, at least at some point, that tumor could not fix its DNA. On the right-hand side, you see homologous recombination repair panels. These, you have a panel and it says you have a PALB2 mutation in your tumor, or you have a RAD51C mutation. And so the inference from that is that you will be sensitive to a PARP, or you will have a deficiency in how your tumor repairs DNA. But maybe you do, or maybe you don't. Maybe that mutation is doing something, maybe it's not. So it's looking at, it's identifying a potential cause for homologous recombination deficiency, but it's not confirming that the deficiency is actually there. So hopefully that makes sense. One picks up the consequence, one identifies a potential cause, and they're different. So let's go through these assays a little bit. So this is a comparison of the assays that are available in the United States. These are the FDA approved assays to date. On the left is the Myriad My Choice. It has 3 components. One is called loss of heterozygosity. And so what that means, well, I'll come to that. Loss of heterozygosity. One is called telomeric allelic imbalance. One is called large state transitions. And all of these changes in the chromosome contribute to homologous recombination deficiency. And so they're detected, and then a score is assigned. And if that score is 42 or higher, or the patient has a known BRCA mutation, irrespective of the score, they're determined homologous recombination proficient. And this gets confusing sometimes if you don't know the abbreviation, but they call this a genomic instability score, GIS. So if you see GIS, that's genomic instability score, and that refers to this homologous recombination assay. So if it's 42 or higher, it's considered deficient. And if it's less than 42, it's considered homologous recombination proficient. And then sometimes the test doesn't work and they can't tell you. The foundation test only has loss of heterozygosity, and or you have the same thing. If you have a germline BRCA, you're determined to be loss of heterozygous. Now, I'm going to show you about this. It's not that this is 1/3 of the Myriad test. It's detected in a completely different way. And then the indirects, those are direct ways of measuring homologous recombination deficiency, the consequences of. The indirect way is to find these genes and assume that it leads to homologous recombination deficiency. So direct and indirect assays. So here's the My Choice score and how it was sort of validated. And you can see at the bottom, the 3 components, none of which have a clear breakpoint. And so none of which could be used by themselves to say this group is positive and this group is negative. And the truth is this is a continuum, right? So it's a little bit false to kind of create a 42 breakpoint, but you need a positive and a negative score. But when they combine them, as you can see on the top middle, and then in this figure, you can come up with a breakpoint that that seems to be bimodal. And more importantly, in the group to the right of the breakpoint, that's correlated with patients who have BRCA tumors. So this wasn't developed to correlate with response to PARP. It's since been validated in a number of studies, or not validated, we can talk about that. But this was validated to pick up tumors that looked like BRCA. That's how it was validated. So this 42 score is trying to identify tumors who genomically look like tumors that have a BRCA mutation. And that's where that 42 score came from. So the big part of this is what's called loss of heterozygosity. And we evaluate this with single nucleotide polymorphisms, or SNPs. And just to remind us all, we know this, right? We're all born with a chromosome from our dad and a chromosome from our mom, and they're entirely different. And so they're heterozygous, right? So heterozygosity is good. When you have loss of heterozygosity, it doesn't mean that gene becomes the same. It just means you've lost one. So you've lost heterozygosity because the other parental gene has gone somewhere else. And you kind of see all the reasons that this can happen. It's really complex. You could lose a whole chromosome. Well, then you lose all heterozygosity. You could have a deletion. You could have an unbalanced translocation. You could actually duplicate the gene and have loss of heterozygosity because they're both the same, and that's in reduplication, gene conversions, etc. And so all of these combined equal loss of heterozygosity and lead to homologous recombination deficiency. And they're measured very differently. And so this is the thing I like to emphasize, because we have these two tests, the Myriad genetics test and the Foundation 1 test, and they're both good tests. But we don't know which one. They overlap, but they're not the same. So we have to be careful with that. They're not the same test. They overlap a little bit, and who knows which one is right more of the time. We have no idea. And so that's just some of the things we have to sort out. But just to tell you, the LOH in the Myriad test is determined as I've defined here. It's the number of loss of heterozygosity regions on the chromosome greater than 15 megabase. And so those are counted as an unweighted component of the score, the genomic instability score. In the Foundation 1 LOH, which is a whole test, right? That's all they're looking at. They're looking at a loss of, any loss of heterozygosity in the chromosome is counted, and they just total it. So if 16% of the chromosome or more has loss of heterozygosity, that's called a homologous recombination deficient tumor. And if it's less than 16%, it's called homologous recombination proficient. So you could see how those two tests could differ. And again, we don't really know which one's better. That's kind of a problem. And so we have all these tests you can send. You're trying to individualize for your patient and pick the best test for her. We're starting to see some comparisons, and there's some big phase 3 studies in ovarian cancer that are going to result probably in the next couple of years that incorporate all of these. So we're really going to get a sense, I think, of what the best test is. But this was from Paula. It was a subset analysis. So, it's exploratory, but it's interesting to look at, where they stratified by BRCA is appropriate. And they did use the Myriad Hrd assay for subset analysis. So they have that in everyone. But they also looked at this homologous recombination repair gene panel. So one of the gene panels I talked about, to see if it predicted better who would respond to PARP. And so here is the data. So I think it's quite interesting. I want to see some additional data, but you can see in Paula, on the left here, the breakdown of those that were HRD positive in blue and HRD negative or unknown because the test failed in gray. And then the BRCA and the non-BRCA are separated out. Here's layering on the patients with a positive homologous recombination repair panel in pink. And so 2% of them fell, first of all, it was really infrequent, number one. We found them very infrequently. Second of all, 2% are in that blue, in the homologous recombination deficient group, but the other 4% would have been classified as homologous recombination proficient or unknown. So they don't all track with homologous recombination deficiency, which is interesting. But if you look in the box in the middle, it's only 7% of the whole population had a positive homologous recombination repair gene finding on the 13, they had a 13 gene panel. So it's really infrequent. And then they looked at, again, the mutations in non-BRCA. So they excluded those patients with BRCA, but otherwise had homologous recombination repair genes. And they said, okay, if you have a mutation, what's your genomic instability score? And less than 50% of those tumors that had a homologous recombination repair gene mutation, like say a BARD1, less than 50% of those had a genomic instability score greater than 42. So they were mostly characterized as homologous recombination proficient. And so you might say, well, you know, so what if they don't correlate with one another, which one best predicts response to PARP? Because that's what I care about, right? And so here's exploratory, but here's this response in Paula. No matter how you slice the homologous recombination repair panel, like if you made a really big panel, if you made a little panel, in terms of the number of genes, it did not at all predict response to PARP at all. It was non-predictive. So that's interesting. It's in a subset of patients and it wasn't a pre-specified analysis. So I think we have to take it with a grain of salt, but I think for now, it tells you that if you were using those homologous recombination repair panels instead of any one of the HRD assays, Foundation or Myriad, to pick patients who might benefit from PARP, I would probably be relying more on the HRD tests. And again, I can't tell which one is better than a gene panel, because the gene panels, at this point, we don't have evidence that they are predictive. But HRD assays aren't perfect either in individualization to patients. So, you know, this is where it gets frustrating. We don't have all the answers yet. It can really be a fossil record sometimes. And so why that is at some point at the beginning of the tumor, before it's been treated, as I mentioned, it may have all these inherent vulnerabilities to how it fixes its DNA. And be very sensitive to PARP inhibitors. Okay, but over time and with treatment, that tumor changes. We know this. It becomes more resistant to things. It develops ways to become homologous recombination proficient. And so even though the HRD assay will still pick up the evidence that the tumor at one point couldn't fix its DNA, it's like the fossil. You'll find the fossil, but it doesn't tell you right now what the tumor's behavior is. And so that's one of the limitations in the recurrent setting. I think in the frontline setting, it's a pretty good representation of what's there with some caveats. So, but in the recurrent setting, even if you're looking at a new biopsy, you're still going to detect the fossil. And so that's one of the limitations, is we don't have a real functional assay of what's happening now in a tumor once you're recurrent. Not for lack of effort, but there's just not been anything that's been kind of easy to use that reflects what the tumor is doing now. So I still think there's a lot of work being done on these assays right now. There's many companies developing liquid-based assays, kind of cool stuff that's being tested in frontline studies. So I think these assays are going to evolve over time, much like the dinosaurs evolved or de-evolved, I guess. So I think we're going to get better, but these are pretty good tests for now, especially in the frontline for detecting who will and won't benefit. But then let's just get into the clinical data. So that's the assays and how you individualize. I mentioned to you that in the day, all we did was Taxol and Carbo. And so I'm reminding you, although I think you all know this, what happens if you give paclitaxel and Carbo alone. And this is ICON 8, which wasn't presented that long ago. It was 2017. This is going to be the last big phase 3 study ever that doesn't include maintenance or stratification by BRCA or a targeted therapy. This was solely chemo given in 3 different ways. And it didn't matter. We know that. But the importance of this is just to remind us what happens when you use paclitaxel and Carbo alone. And what you can see here is this 20% of women who recur within 6 months of their completing chemotherapy, this primary platinum resistant population, which is a very poor prognosis. So eliminating this is a high unmet need. And then by 3 years, 80% of women with high-grade serous and high-grade endometrioid, or even clear cell, probably shorter than 3 years, will have recurred. And once recurred, we have a lot of things that keep them alive for a very long time, which is good, but they're no longer curable. And so if we're going to impact that and create long-term disease-free survivors, we've got to do better in the front line, at least until we can screen and prevent these dread diseases. And so that's really where the focus has been. Now, the first big benefit was bevacizumab, and I'm not going to belabor this because you know this data well. This is ICON 7 and GOG 218. Both were positive. Both had primary endpoints of progression-free survival, and both showed a reduction in the hazard of progression or death of 20 to 30%, which is pretty good. No overall survival advantage, but you did move the curves a little bit to the right and improve the progression-free survival for patients, irrespective of biomarker, because there weren't any, and there still aren't any. So this was an important, if you like sports, like a base hit in baseball. And remains a very important part of our armamentarium. Now, when these were presented in 2010, it's a long time ago, what's the first thing people said? Well, look at those curves. They come back together as soon as you stop the Bev. So maybe we shouldn't stop the Bev. Maybe we should continue it for forever. And why do people ask this question? Not just those studies, but every study of bevacizumab, when you stop the Bev, the curves come back together and they make a banana, called the banana sign. So the BOOST study asked, well, don't stop the Bev then, and maybe we'll improve survival for patients. So this is one of the first big pushes to improve survival. And there was a very simple question, 15 versus 30 cycles of bevacizumab post-Taxol carbo. And I really thought this was going to be positive, but it was not one bit, not one signal that this improved progression-free or overall survival for women with ovarian cancer. And so those of us who were early adopters of this need to stop, because all we're doing is adding toxicity, which was surprising to me, but true. So negative studies are very important, and bevacizumab remains important, but for 15 cycles. But really the big benefits came with PARP inhibitors. And since 2014, every new approval, except for the 2 for bevacizumab, have had a PARP therapy, both in the EMA and in the FDA. SOLO-1, we're talking about frontline, was probably one of the most transformative studies, if I do say so myself, because it hopefully will improve survival in the frontline. We'll see. It's too early to know yet, even though we're 6 years out, still too early to know because patients are doing so well. But to remind you, this took patients, it accrued in 2013. So it's an old study. We would have designed it differently now. But 2013, we enrolled women who had BRCA-associated cancer, advanced, and had responded to platinum-based chemotherapy surgery combinations. They had to be in a partial or complete response. And then they were randomized 2-to-1 to olaparib 300 twice a day or placebo until toxicity or progression, or if that didn't happen, 2 years. And the 2 years was picked because the FDA said you can't treat forever, which was our original plan, because we felt these people were so high risk, and they said no. And so we picked kind of 2 standard deviations from the control arm, which was 13 months. And so that's where the 2 years came from. A little bit arbitrary, but a little bit planned. And the primary endpoint is progression-free survival. So here I'm showing you the progression-free survival to the 2-year cap. And so one of the things I want to point out to you is that in the group randomized to olaparib, which is in maroon, that 20% of women with platinum-resistant disease is gone. Only 4% were platinum-resistant and primary platinum-resistant. And you might say, well, that's because they're all BRCA, and BRCA patients are cured and they do amazing. They don't. They're high risk. Look at this placebo group. It's 20% recur in 6 months, which really surprised me because I had the same belief that these patients didn't ever have primary platinum-resistant disease, but they do, and they do just as poorly. And so we eliminate that with olaparib. So that's critically important. And at the 2-year mark, 74% of women versus 35% of women were progression-free in the olaparib and the placebo arm. And then we stop it. And so if you stop bevacizumab, they come back together and make a banana. Here, they don't come back together and they remain parallel. I'm showing you the updated data that Susanna Banerjee presented at ESMO last year, or this year, last year. That shows us out to 5 years with about 50% of women randomized to olaparib still disease-free as opposed to only 21% of those women randomized to placebo. Now, some of those women in the placebo arm are cured and they didn't need anything. And so we'll figure out what percentage of women are actually cured when we get to that point, probably in 2023. There are some women that don't need anything. And if we can identify them someday with ctDNA or something else and spare them maintenance, I'm all for that. But it's not a big proportion of this population. And so we really should feel comfortable with this data that we're doing the right thing by assigning maintenance and stopping at 2 years. Now, that was just in BRCA. Then we had the studies that expanded beyond BRCA. So this is PRIMA, which was similar. It took patients who were in response to their frontline therapy, platinum-based therapy with surgery, and randomized them to niraparib, 2-to-1 to niraparib or placebo. And here was different though, because it was all comers, high-grade serous, high-grade endometrioid, and it's stratified by HRD, by the myriad test. And so if you were BRCA or you had a score greater than 42, you were classified as homologous recombination deficient. And that was a key stratification factor because the endpoints are progression-free survival in that group, the HRD group, inclusive of BRCA, and then in the whole group. So 2 subsets in the primary analysis. Now, PRIMA was a really different population purposefully by study design than SOLO or PAOLA. It enrolled basically some of the highest clinical risk patients I've ever seen. Almost 70% were dispositioned to neoadjuvant chemotherapy. I've never seen that in a frontline study. 35% stage 4, and over 30% came on study with a partial response, and then were randomized to placebo or niraparib. So clinically a very high-risk group. And I just emphasize that not to be critical of the study. I'm not critical at all. But you can't compare the median progression-free survivals across these studies because they're very different populations. So just you have to look at the hazard ratios. So just prefacing that. So here's the endpoint in the overall population. So everybody, irrespective of biomarker, who were in response to their frontline therapy, if you used niraparib, you reduce the hazard of progression by 38%. That's pretty remarkable. That's a very clinically and statistically significant reduction in the hazard of progression. If you just look at the homologous recombination deficient population, you reduce the hazard of progression by almost 60%. So that's very striking to me, and should be to you. In all comers it works, and that's why it has an all-comer indication. But in the biomarker selected group, it really does identify a group of patients who have a pretty transformative reduction in their risk of progression. And then if you look at the breakdown, these are exploratory endpoints. From left to right, it's BRCA-associated cancers with a hazard ratio of 0.4, so a 60% reduction in the hazard of progression. In the middle is this group of women, it's about 20% of our patients are BRCA wild type, but are HRD. I'm interested in this group in particular. Here you had a 50% reduction in the hazard of progression. So it's a no-brainer that a PARP makes sense in this population. And even in the homologous recombination proficient group, you see a 32% reduction in the hazard of progression or death. And this puzzles people as to why this works here, but it shouldn't, because, and I'll point this out in PAOLA is why it's different. In this patient population, these were very high-risk patients. They had disease basically when they came on study. You couldn't come on PRIMA if you had a stage 3 cancer and you were optimally cytoreduced to nothing. You weren't eligible for PRIMA. To come on PRIMA, you had to have disease that responded to chemo. You've proven that the chemo was important in the response. So you've identified, that's the clinical biomarker. You've identified a group of patients who are, if you call it platinum sensitive, I don't know if you can say that, but they had to respond to their platinum, right? You've eliminated that group of patients who you operated on, got everything out, and then gave them chemo. You don't know that the chemo helped them at all, right? Your surgery set them up to be no evidence of disease. You presume it did, but you don't really know. Here you knew. These patients were very high risk and they responded. That clinical biomarker, even though you have a negative somatic biomarker, the clinical biomarker still tells you that that patient's going to benefit. And I think that that's important to recognize in this high-risk group of patients. Now, PAOLA is different. PAOLA is more similar to solo in terms of its risk group, not exactly the same, but a little more similar. Took patients in response to their chemo plus bevacizumab. And why is that? Well, in many parts of the world, bevacizumab is the standard of care in frontline, and it's the only place they can use it. They can't use it in the recurrent setting multiple times like we can. And so they're not going to use it. They're going to use it. And they wanted to say, well, can I add PARP? And so that's why the study was designed. So patients had to be in response to chemo plus Bev, and then they were randomized to Bev alone with a placebo versus Bev plus olaparib. And it was stratified by BRCA, but otherwise enrolled everyone, high-grade serous and high-grade endometrioid. And the primary endpoint was progression-free survival, which you see here. So as compared to an active control, which is bevacizumab, addition of olaparib to bevacizumab reduced the hazard of progression by 41%. That's the primary endpoint, which is why I think this should be approved in everyone, but it's not. Because of this breakdown, again, just like I showed you on the left, you see the BRCA population, which has a hazard ratio of 0.33, so excellent. In the middle, you see BRCA wild type HRD with a reduction in the hazard of progression or death of 57%. That's amazing, versus an active control plus Bev. But in the HRD unknown, there's no difference over Bev. And why is that? Well, number one, Bev is an active drug. And number two, as I was saying, most of these patients came on, many of them came on no evidence of disease because they had been excellently cytoreduced. And so they didn't prove they were platinum responsive, which is the clinical biomarker for response to PARP. And so you had a group of patients that came on that you really don't know that they're truly responding to their platinum. And so, you know, that may have kind of washed out this group. They are different populations, and so you have to think about that. I like this combination, and I would like it still in a prima-like population, even if they're homologous recombination proficient. I don't think this tells us that the combination isn't effective in HRP. It tells us it isn't effective in this population, and we need to sort that out because it's an important question. And so when we think about these studies now for Paula versus Solo, specifically in BRCA, you might be saying to yourself, well, do I need bevacizumab? Should everybody with BRCA get bevacizumab? Does anybody need bevacizumab? Can I just give them a PARP? What do I do? We don't know the answer because Paula had a missing arm. It didn't have a BRCA or PARP alone arm. But we did do this propensity analysis that I'm showing you here on the right. And it just came out in the European Journal of Oncology. Ignace Vergote is the lead author. I'll update this reference, but it just came out so you can PubMed it. And basically we took patients from Solo 1 who got olaparib and who clinically looked like the patients who were BRCA on Paula. So we recreated the missing arm of Paula with patients from Solo 1. So exploratory completely. But we just wanted to see what the impact was. And you can see it here. In green is the combination, and pink is single monotherapy PARP, and the hazard ratio is 0.71. So it looks additive, not synergistic. So you get a bump. So it is good, but it's not a synergy. And so what this allows you to do is dissociate your decision for bevacizumab and PARP. If you want to use bevacizumab because you like it, I like it. I use it on almost everyone. Or if you want to use it because they're stage 4 or they're suboptimal or whatever, use it. Make your clinical decision for Bev. You normally make that decision before you know the patient does or doesn't have BRCA, right? So make the decision, use it or not. And then if you find somebody that has a BRCA, if you've chosen not to use it, feel good about just putting them on monotherapy PARP. That's fine. If you do have it on, layer on the PARP and you have all of the safety data to counsel your patient. Both are fine, as long as you include a PARP. The wrong answer is not giving a PARP or using Bev alone. That's the wrong answer. As long as you're using a PARP, you can use Bev when you need it or not. Totally believe that. Now we can't do the same fancy analysis for BRCA wild type HRD because that particular population only exists in Prima, and Prima and Paula are such different clinical groups that you can't combine them. And so at this point, I think we have to say the same thing, is that you dissociate your decision for Bev and PARP based on, in the US, we can only use this combination in HRD anyway, and you dissociate your decision just like you do at BRCA. I am interested though, based on the platinum sensitive data in BRCA wild type that shows that this combination of anti-angiogenic and PARP is synergistic. Joyce Liu and Mansur Mears I have presented on this. I do wonder if that's the better regimen in this BRCA wild type HRD group. And I really want us to do a trial just in that group, comparing PARP alone versus PARP Bev. But until we have that data, I think you have to face your decisions, just as I said previously. And then HR proficient, PARP works, especially in someone that's responded to platinum. It doesn't work as well as the other groups, but if your patient's HRP, but she's responded beautifully to the chemo you've given her, she's probably going to benefit from PARP. So don't overthink it too much. You know, I think there's definitely a role for bevacizumab or PARP, and you have to kind of base it based on the known response to platinum and your other clinical features. But this is a group of patients for whom we need to do a lot better than just PARP, and there's trials actively looking at this now. And in case you were hoping that immunotherapy would fix this, it didn't. We have two big phase 3 studies, one called Javelin 100, one called Imagine 50. I led Imagine 50, incorporating immune checkpoint inhibitors into frontline ovarian cancer, and both were negative. And you guys know this, they've both been presented and published, Javelin 100 on the left and Imagine 50 on the right. Zero indication that this benefited patients, even in subgroups, PD-L1 subgroups. PD-L1 was a fully powered endpoint, and Imagine it was a subgroup in Javelin, irrespective, there was no signal that it worked. Maybe in the really high PD-L1 positive, we saw a signal in Imagine, but this was a subgroup analysis and wasn't controlled for other factors. And so we have to consider it only exploratory at this point. And it's unlikely, honestly, that this is real, as much as I'd like to make it real. And it's only 20% of the population. And then in the patients who are germline BRCA, where we thought maybe it would work really well because of the elevated neoadjuvant antigens, we saw nothing, like absolutely no benefit. So if you're one that likes to add immune checkpoint inhibitors, I see that in the US, I don't know how it gets paid for. It doesn't work and doesn't help patients. And you do run the risk of significant IO toxicities, which I've definitely seen. So unless they're going on a trial, I would not recommend this. And we do have trials ongoing. These are the 4. They've all finished accrual. These 3 all have the triplet of bevacizumab, a PARP, and immune checkpoint inhibitor. And they'll start reporting out probably early 2023. So we have a bit to wait on these to really see if there is any role for immune checkpoint inhibitor in ovary, high-grade serous, high-grade endometrioid. I'm not talking about clear cell, which maybe does have a role. So we're gonna have to wait and see. And so just to quickly end, if we're gonna use that all up front, what do we do here? You know, when patients recur? So we have the OREO study, which I should have updated this, I forgot. It just presented last week. Retreatment with PARP works, actually. Who would have thought? And again, coming back to my earlier point, it doesn't matter if you're BRCA or not. Both worked, BRCA, non-BRCA, because you had to prove that you responded to the platinum again. So re-response to platinum after receiving a PARP, like being in a complete or partial response, was the clinical biomarker for whether or not PARP would work. So that's something. So we do have data that supports PARP after PARP from ESMO now. Now, I will say they don't do very well. And so I think we need to do better with combinations. But as compared to placebo, the hazard ratios were quite strong. And so this is a new thing as of 2 weeks ago. So we're going to have to digest that. We also have to figure out better how to overcome PARP resistance. And that may come from restoring homologous recombination deficiency that's been lost over time with mutations. We're studying reversion mutations now. We're identifying them, clinical trials only, but these assays are coming. This is from the Ariel program, which basically says if you detected a reversion mutation, and in the bottom figure, all the bars with stars on top, and they're all on the left-hand side, you didn't respond at all to rucaparib, period. And so if you have a reversion mutation, we shouldn't be using monotherapy PARP. Does that apply to combinations? Remains to be seen. This paper I just put up here for reference. I know this is a complicated slide, but reversion mutations are basically mutations that have been repaired by alternative DNA repair machinery like DNA PK or MMEJ. And they leave signatures as to what's repairing the mutation and restoring the reading frame. And we may be able to target that with DNA PK inhibitors and pol theta inhibitors. And those are just entering the clinical arena now for incorporation into some of these trials to see if we can either prevent or reverse reversion mutations in patients. So these are just entering trials, and I think are high unmet need. We've tried a lot to do combinations to reverse restoration of homologous recombination proficiency. And this I'm just showing you to show you how complicated this is. We all thought we could just do a combination and make this work. This is Stephanie LaRue's EVOLVE study, where she enrolled women who had progressed on a PARP, and then she got a biopsy and gave them olaparib cediranib to try and overcome it. Lots of preclinical rationale to do so, but it didn't work. Didn't overcome resistance in any of them, but the biopsy showed us how complex the issues are. You know, she had BRCA reversion mutations, she had RAD51B mutation reversion mutations, RAD51C overexpression, which is important, SLAFN11, cyclin E amplification development. So remember, that's mutually exclusive from a BRCA patient. At baseline, you don't have both, ever. But over time, apparently we develop it. And so we're going to have to figure out how to detect those, because we're starting to be able to target cyclin E amplification. So her work kind of is humbling, because it shows us how complicated it's going to be to overcome restoration of homologous recombination proficiency. But these are the studies we need to be doing. Probably our biggest hope comes in targeting the replication fork with ATR, CHEK1, or WEE1. And we know the ATR story, so I won't belabor this, this figure, other than just to remind you that the replication fork has to slow down in order to repair the DNA. And that's controlled at DNA checkpoint 2. And so if we take out ATR, WEE1, CHEK1, and prevent that slowdown of the replication fork, it will lead to replication fork collapse and the cell dies. So this may be a strategy in a post-PARP setting. We've seen early indication of this working in the CAPRI study. So this is ATR plus PARP in a platinum-sensitive, PARP-resistant population with a response rate of 46% and a progression-free survival of 7.5 months. And you can put that up against Oreo now, and that looks pretty reasonable. You know, in a third or fourth platinum-sensitive recurrence, that's actually a reasonable benchmark. So this may be something that should move forward. This is a small study, but proof of concept. Probably the more exciting is WEE1 and olaparib that Shannon Weston presented versus WEE1 alone in a PARP-resistant population, only PARP-resistant, as you can see here, mostly platinum-resistant and PARP-resistant. And in the BRCA population, interestingly, the responses weren't that great, 20%, that's okay. Clinical benefit was pretty high, but the responses weren't that great and the duration was okay. It was kind of meh. But in the wild type group, you had a 31% response in WEE1 alone and 40% in the combo. That's pretty high in a PARP resistant population with an 8.4 month duration. So I'm excited about this, except for the toxicity. I still think we need to work on it. But these are the types of studies that are going on right now that hopefully will benefit our patients in the future. And so with that, I think the key take homes are individualization of therapy is here. The tools are getting better for us in terms of upfront prediction with the Hrd assays. They're getting better. The reversion mutation is coming, and those are going to be essential in clinical trial design and clinical management, because you're not going to use these drugs if you can tell right up front that it's not going to work. I want that. I want to know when I shouldn't use something, and so do you. So those are coming, and that's going to help us individualize what we should and shouldn't use. Understanding PARP resistance is the next big thing. We're already doing it, but the work is hard and requires the type of scientific work that Fiona Simpkins and Panos Konstantinopoulos and Shannon Weston, you know, we have very, very bright people working on this right now. And they're going to help us figure out how to individualize. Liquid biopsies may help us do this rather than trying to biopsy the tumor every time, right? That's hard. Liquid biopsies are coming. We may be able to individualize there. And I think hopefully you've seen from this, just the quality of the science that's going on right now is so high. It's so much different than the olden days where we just gave drugs empirically to patients and saw whether it helped. Those days are over. And we really are being more selective with clinical biomarkers and molecular biomarkers to identify the right patient, the right drug, and the right time to better enhance our patients in survival and quality. So I think it's an exciting time, and I'm looking forward to the next few years to see what comes out. And I'm happy to take questions. I'm sorry I went over. Thank you.
Thank you, Professor.
That was too long.